Thanks very much, and thanks for inviting me. I think this is something since I got involved with our patient safety teams in the ICB through a group called Transferring Care Safely, which I'll go into a bit more detail in a second. This has been the reason I don't go out and go to all these lovely conferences that Nikki loves going to, but I don't get the time to because I've just got to sort out the problems that we've got at home, and these are replicated almost if you go to any. I'm not singling us out here, and I'm not, but any system in the UK that employs EPRs and they all do now, this will be something that will be rife within them. So I just want to kind of highlight it. I've only got 4 slides. I really just want us to have a really good discussion about what we think the answers are and how we think we can get a bit better at doing this. So without further ado, firstly is the CCIO and ICS, and it was really good to hear all of you introduce yourselves because it kind of allows me to understand where you all are in the kind of digital spheres. But when I first became an ICS CCIO, there wasn't really any blueprint for me to work from, or any kind of job description. It was really, let's just see what we can do. We had a really good digital delivery team and strategy team that really kind of pulled together all of the people that were working in our ICS, so all the way from, and it has grown, I must admit, since we've become an ICB, but we had what I think some of us will remember as an STP footprint, and that allowed us to have these discussions, and I think we'd been having them for our predecessors, had been bringing together local authority and acute trust, community trust and GP digital leads for about 10 years. So we've been doing all right in Leicestershire. We're one of those that seems to have got a hold on the importance of digital going across the whole system. So how I kind of approached it was, well, people came to me with things that were going wrong. And I think that's probably the easiest way to describe the way my role has kind of come along in patient safety, because you tend to be from everything from IT support for your clinician colleagues all the way through to, oh my God, how are we going to sort out this? Because it's a massive problem with patient safety. So from one end of the spectrum, you can go turn it on and off, it'll be fine, to the other end where you are in some serious discussions with, or kind of trusts, and even going back to suppliers to say, come on guys, what are we going to do about this? So the way that we pick up on these things is there's a few different touch points that you really can't do without in a system. One of those is making sure that you've got your GPs together and that you can talk to them across the board. So we set up something in Leicestershire called the GP IT Forum, and again, normal Teams meeting, same time of the month every month, and we've got 126 practices, all with their individual solutions and IT going on. They're all on system 1, 91%, EMIS 9%, and we got together because all of us were having the same problems and we wanted to share understanding, learning, etc. You know how it is. So we did that, and actually what started to happen is there came a bit of a movement over how can we make things easier. So we had some our colleagues over at the Acute Trust, Jeremy, Steve, the guys that are really interested and clinical, which is really, really important here, is that they understand how these processes work for people that are actually trying to deal with patients as well. They understood quite how difficult how their IT systems were making our IT systems. So for instance, let's just take one example about paper and letters. So digital, electronic via mesh letters and paper. The fact that GP surgeries were processing paper as well as the digital copy of it, it was so much for admin teams to do, to work out which one have we got, which ones we need to shred, and which one's the most to-date version of the truth that has been the last digital copy to come through. So we had duplication to deal with. And the next thing was, okay, the patient safety team is knocking on my door and saying, look, we've got these things happening across the system. We really do think that in our transferring care safety board that we need somebody digital that can oversee the whole system. So I started joining them, and that's where you start to see the coroner's cases come through around digital handovers being less than efficient or less than safe. So some of those really caught my eye. Some of the things that both hospitals were worried about that fed into the TCS, transferring care safely system, and some things that the GPs were quite vocal about were feeding in as well. And it allowed that digital oversight of the system that I think when I go and talk to other areas, sometimes their CCIOs are just nominated and they are the medical director, but they happen to have the CCIO role built in, but they're so bogged under with what they're doing with medical directorship that they can't get to any of this other stuff. So the role of the CCIO in the ICS really is one of those things that I think we should start to highlight now that we're becoming that digital entity as a health system. So we put that as part of the digital strategy. When we started as the ICB, we formed something called the Digital Advisory Group, which is people like Jeremy, who's on the call. It's really nice to have him here. Steve and their clinical digital team, CNIO, the chief clinical pharmacist, all join the Digital Advisory Group for the system. We've got people from our acute trusts, the CSOs. I'm really, really keen on having the CSOs in that group, and some of their CCIO colleagues, etc. We're trying, but it's really difficult because there's not often anything really for local authorities to get their teeth into on these meetings, and that's often part of where we're falling apart, I think, is that we need to get more local authorities engaged with us, and make sure that when we're talking about things across the whole system, we're including our social care colleagues as well. So it forms part of the digital strategy, and these groups that we set up have the governance which sits under it to allow problems that are found in some of these areas to actually go straight up into the digital strategy, but also across into exec teams, and then back down into organisations like Leicester Partnership Trusts, UHL, and those other places that we're all working with. I mentioned transferring care safely. It was a group that was started by our patient safety teams in the ICS, and it really has gained momentum. It's sorted out things like letters. It's sorted out kind of back office numbers for GPs, which we're really struggling with. So all of those types of things that improve communications across the board all come to there. I've talked about the GPIT forum, but the real thing I want to highlight today is what's going to happen with the new model blueprint. How are we going to keep this oversight digitally when the model ICS is devolving digital to providers? That's one of the biggest areas that I think we as CCIOs have to be really, really aware of and make sure that we keep that oversight. Further to that is patient safety teams. It's a little bit of a grey area. Are they going to go regional, or are they going to go down to provider, and where's that in between going to be? We're going to have to cut staff. It's quite a significant cut that both trusts and ICSs are going to have to make, that we're all aware of. How on earth can we keep these patient safety teams and digital teams? Because we know that's the future. We know that a lot of our services rely on it. Let's make sure that we don't make the mistakes of getting rid of the people that have had the legacy systems and understand them, and how that we can evolve safely into using newer and newer platforms, and keeping the platforms that we've got safe. So I wanted to talk about some examples that we've got in our system, and please, all of this stuff goes through our kind of public boards and all the rest of it. So none of it, I don't think, is a secret. They're all on the quality groups. I'm just being open and transparent because I think we've got to start somewhere. I think if I'm honest with what we've got in our area, I want you all to look in your area as well and see what challenges you might have that are along these lines. That's part of what we want to do with the regional teams and the patient quality groups regionally as well, is start to have this proper conversation around EPRs handing over to each other and how we can influence suppliers and national teams. So there's discharge letters that we know across the country have been a problem. That there is often the reliance on those staff that are on the wards that are performing really pressured duties, a lot of care where they're under pressure to discharge patients, and the EPR and the notes that go alongside that are another burden for them. I'm not, and this is in no way blaming those people that are on the wards and that are performing the amazing duties that they are for our patients. This is around, let's help the technical solution actually work with them rather than against them. So the problem across the country, and I think it's okay to say that we're having a similar problem as well, is that the discharge letters are there, but actually it's gone through many different people. They've had different sections added to them, and everything's been updated, but nobody's pressed that button to send it to the GP once the patient's left the building. And of course, it builds up on a server somewhere, and once that server starts falling over and telling people about it, that's where the problem's realised. The similar, so that's across two separate EPRs. Obviously, you're going via mesh in between. But if you start to look at something like System 1, which is all one system, we're a complete TPP area. So we have 91%, as I said, GPs on it, but we've also got our community health trust on it. We've got our mental health trust on it in the community, and we've got our CYP community trust. So we've got 3 separate units, TPP, all on the same system. Beautiful, you think? Wonderful. It's going to work really well, surely. Well, actually, I think it's a bigger problem than the previous problem I was saying about discharge letters. In System 1, the sharing's enabled. So if you have somebody that's on a separate unit, let's say it's mental health, they're writing a letter and they get to the point where they've finished their letter. That letter, once it's finalised, actually is shared into the GP system, so the GP can see it. However, if they miss the final step, which is the same final step that's on the hospital EPR, press it to send via mesh, of course, it never goes to the GP and it never gets pulled into the system in the normal way in that GP surgery. So it never sits on the GP record. So the GP can see it once they open the patient. They can see the letter and go, "Oh, didn't know that was there. Okay, well, we'll have a look now. The patient's contacted me about something that's been said in the mental health clinic that they went to, and they were expecting some tablets. And I go in here, I see, oh, there's a letter here. I wonder, it must have been just missed by my admin team. No worries, we'll sort you out now." However, that letter never came to them because it was shared. So it wasn't notified to them. It's just visible to them. Now, if you think how that's going to affect the way that that's seen online by the patient, so accelerated record access, it will never form part of the GP record. So that letter, the clinician at the other side in the mental health trust feels that everything's done and it's gone. But it's not gone, and it's not part of the GP record. And that is where we're seeing a lot of errors over whole departments in our community trusts are doing it in the wrong way. The admin person that sends the letters has just thought, oh, this is the right way to do it, and not done it in the right way. We don't know what that's going to mean for the backlog. We don't know what that's going to mean, or if it has already formed some patient safety errors and issues that are along the line. So that is what I wanted to raise for even when you're on the same system. you can get these errors. And it all comes down to the digital understanding that those admin teams and those clinical teams have in those separate units. We had an example as well of transcription errors and delays when we're discharging people from hospital, acute hospital to community hospitals. You think, okay, that's going to go smoothly, but if they're discharged at night, which they often are, let's face it, we need to move beds along, and it's often night times is the time when people have just got a breath of fresh air. The transfers can actually work because the ambulance services have got enough people to move them around. Then when they get to that other side, of course, they need transcribing onto the EPMA, and all the stuff that was on the ward on the other side needs going over. So we hit another problem where we couldn't get a member of staff to do that transcription. And it needs to be somebody that's qualified in using the EPMA so that they can work it through. So there's lots of examples of the handover of digital care providing a problem to the system. And of course, when we're in our trusts, what we want to do is make our trust really effective, and it ends where the patient leaves the trust. But I'm really worried in the new blueprint for the ICSs, where's that going to be picked up when the issues are going in between those two EPRs? I'll put some more examples there. You probably know about them already. Pulse ran a massive article, 700,000 letters on an FOI request across the nation were found to be missing, not sent to GPs. And then there's Cobham Warwick's very recently sent 15,000 letters on one day because they wanted to kind of clear their servers. And that burden on general practice, I cannot tell you how much that is a problem. All right, that's going to be patient care being affected because the admin teams have got a massive backlog that they've got to get through. I think we're all aware of the 2017, I think it was, 400,000 letters, and then Newcastle started it off with a measly 20,000. It seems small now compared to the other numbers, doesn't it? But that was probably the first example that got into the press. So what does the future hold for all of this stuff? I think that's probably what Ming and Vin are thinking about when they're thinking about the single patient record. Let's just take the burden off, and let's make sure that letters are all put into one place, and then we all look at the one place and everything's there for all of us. Sounds wonderful, doesn't it? But we all know 15 years ago that we tried to do that and it came a cropper because we got so many legacy systems that we're trying to work through. How's that going to actually work? I think we ought to be calling more on our shared care records. Those are the ones that we've already got up and running. The interop's all there. We've got the surfacing of the data. How can we use our shared care record in a better way to work that through? But ultimately, we've still got to do the job that we've got to do, which is send the letters to the GP in the right way. And until things change nationally, if the infrastructure changes, fine, fair enough. But at the moment, we've still got to do that job. How do we as CSOs flag, or CCIOs flag this in our systems and raise it? I think we've all probably encountered the same problems. It's just how much you're allowed to talk about it and how much you're allowed to kind of raise it, and who can you raise it to in the system that you think will listen. And how do we raise this with suppliers? How can we make suppliers adapt to the pressures that clinicians have got and actually make things easier? How can we use AI to make that summary of the discharge letter and link the discharge letter and the patient notes to the hospital bed management system? So when the patient's left, actually you've got a validated letter, it just goes. You don't have to press a button. It's not an extra job for somebody. How can we listen more to what patients are going through in that digital handover? How can we engage people like Healthwatch and those people that are stuck in the system there, telling their story over and over again on the way in and the way out, so that they know that teams are listening to them who are providing care directly? And has anyone got any examples of what they've been talking with suppliers about? TPP, EMIS. We've had a good chat with Nerve Centre as well in our area. Thank you all for listening.